Hello, everyone. Good afternoon. Welcome to the February 2026 lecture in the Vermont Center on Behavior and Health monthly lecture series. I'm Steve Higgins, the director of the Vermont Center on Behavior and Health, and thanks to each of you for joining us today. We appreciate it. So we're in for a treat as we have an outstanding investigator, Dr. Craig R. Rush, lecturing today on the quest for medications for stimulant use disorders. Some of you probably know Craig's a professor in the departments of behavioral science, psychiatry, and psychology at the University of Kentucky, an institution that's well known for its excellent research in addiction science. And I'm especially honored to have this opportunity to introduce Craig today, as he was my first graduate student, and I'm proud of him. Craig completed a doctorate in experimental psychology with us here at the University of Vermont between 1998 and 1992. He truly was an outstanding graduate student. I'm not just saying it because Craig can hear me, but it was actually the case. He published 9 articles in peer-reviewed journals, 6 as first author during those 4 years. And the articles appeared in well-regarded journals, including Psychopharmacology, Journal of Pharmacology and Experimental Therapeutics, Neuroscience and Biobehavioral Reviews. So quite a list. And he also wrote during that same period a successful competitive F-31 application, NIH predoctoral fellowship application to study sedative stimulant combinations in the clinical laboratory. And it kind of set a roadmap that his career has followed since that time, really rigorous clinical laboratory studies. And that award funded a lot of the studies he completed during that period. We also had a lot of good times together, including a joint decision to learn to alpine ski, downhill ski together, which was so much fun and has enriched my life for many years afterwards. So from UVM, Craig went on to Johns Hopkins University School of Medicine, where he completed a postdoctoral fellowship with Roland Griffiths, an outstanding mentor and investigator. And Craig again conducted rigorous clinical lab studies, almost exclusively characterizing the behavioral pharmacology of sedative hypnotics, and then continued that high level of productivity, this time with 8 publications in those couple years, again in those same well-regarded journals, JPET Psychopharm, Experimental and Clinical Psychopharm, and again, the majority is first author. And from Hopkins, Craig took his first faculty position as an assistant professor in the Department of Psychiatry and Human Behavior, as well as the Department of Pharmacology and Toxicology at the University of Mississippi, where he joined Bill Wolverton, a senior and accomplished preclinical investigator, and they had complementary behavioral pharmacology labs, Bill overseeing preclinical and Craig clinical research. And they had a terrific 5 year run between 94 and 99, at which time Craig accepted a position at the University of Kentucky, where, of course, he remains today. Um, while at Kentucky for these many years, he's directed the Laboratory of Human Behavioral Pharmacology for almost 25 years, terms as Director of Graduate Studies in the Department of Behavioral Science, as well as University-wide Associate Vice President for Research and also University Assistant Dean for Faculty Affairs. He's had an outstanding record of NIH and other external grant support, starting with that F-31 and continuing right to the present. So Craig lists 53 past grant awards and 3 current awards on his CV, mostly from NIDA, but also NIAAA and a few other non-federal funders. He's been a successful mentor, has an extensive record of professional service, multiple terms as a standing or ad hoc member of NIH study sections, and then a 11-year run as associate editor for drug and alcohol dependence. He's received numerous awards for research excellence, including the American Psychological Division 28 Young Psychopharmacologist Award. And he has had strong research interest in the behavioral pharmacology of psychomotor stimulants throughout his career, including the effects of stimulants when combined with other drugs. And so today he's going to share his what he's learned about this long-standing quest in our field to develop effective medications for stimulant use disorders. Craig, my sincere thanks for joining us today, and the floor is yours.
Well, thanks, Steve, for your kind words. And it's always good to go back to the University of Vermont, and well, not in person. It's still, it was lovely to speak with some investigators there, and uh, fond memories of my years or our years in Vermont. With the fondest being our daughter, who's now 34 years old and the mother of three beautiful little girls, was born at the University of Vermont. So it was a good 4 years in so many respects. So this is a slide Chris wanted me to include to comply with some of your policies. So there we go. And I also want to acknowledge the funding of NIDA over the years. These are some of the grants from which some of the data that I'm going to talk about today were funded by. They had no role in the design or data collection. And, we wanted to let you know that this is content is solely mine and doesn't necessarily reflect the views of the NIH or the University of Kentucky. I don't have to belabor this point to this group at UVM. We all know that the United States it remains in the grip of just an unprecedented drug abuse and overdose crisis. The mortality rates from unintentional overdose deaths they've been steadily increasing for about 25 years, but about 2015 there was this marked increase, and I'm sure you've all seen these data in some form or fashion, and you can see that since 1999, just this steady increase. And finally in 2023, there was this a little dip in showing signs of improvement. And I found some provisional data from NIDA that had the 2024 data in it, and that decline in overdose deaths is continuing downward, which is the good news. But there's still, in excess of 70 or 80,000 unintentional overdose deaths in the U.S. Annually. And we all know that it's largely driven by opiates, and it's largely due to the synthetic opioids like fentanyl, which is probably the single leading opioid involved in this crisis. But amongst this crisis with the opioids, stimulant use disorders, there's a significant public health concern with these drugs embedded in the crisis. And I'm going to touch on that a little later in my talk about comorbid stimulant use disorder and opiate use disorder. In Kentucky, which is very much like Vermont demographically, and it's a largely rural state, there was an increase in rural residents who were reporting non-medical prescription or methamphetamine use, and those rural residents who were reporting non-medical prescription opioid use. And that was a study by Jennifer Havens here at the University of Kentucky. And if you look back a little bit past month, meth use has increased significantly between 2011 and 17 in people seeking treatment for opioid use disorders. So, this kind of sums it. I love this quote from Matt Banks in a book. That should be 2017, not 2027. In a book chapter he wrote that I read, and this was just such a pointed statement. He said, methamphetamine use disorder remains one of the few substance use disorders for which there are zero, and I like that, there are zero candidate medications that have shown consistent therapeutic efficacy in clinical trials. And I think that the chapter was focused on methamphetamine. So, of course, thus the emphasis on methamphetamine use disorder. But I think Dr. Banks could have really expanded that to say stimulant use disorders remain one of the few for which there are zero candidate medications, and that's still the case today. Um, and I'm not going to belabor the negative findings because I could spend multiple lectures going through the negative findings that we've had with these medications. So just to give you kind of the 30,000 foot overview of what's gone on in the past, there's a couple nice systematic reviews and meta-analyses by Brian Chan. And in this one, which focused on cocaine use disorder, 66 drugs or drug combinations were tested. Antidepressants had no effect. Antipsychotics improved treatment retention. Bupropion, topiramate, and stimulants increased abstinence, but even the strength of those effects was characterized as low. But of all those drugs, by far, topiramate and stimulants showed the largest improvements in abstinence. But Dr. Chan and his colleagues concluded that most of the drugs that were tested were ineffective for cocaine use disorder. They also published in the same year a similar systematic review on in the meta-analysis on methamphetamine use disorder. This time, as you can see, 17 drugs, far fewer than have been conducted with cocaine. Methylphenidate, psychomotor stimulant, and naltrexone, an opiate antagonist, showed low strength evidence to reduce use. Anticonvulsants and antipsychotics, opiate antagonists, varenicline, atomoxetine, provided either low strength or insufficient evidence of any effect. So again, Dr. Chan and his colleagues, I think, rightfully concluded that most medications evaluated for methamphetamine or amphetamine use disorder have not shown a benefit. Um, so that brings us to where or my goals for today's talk. I really want to touch on three uh, related topics to medications development. I want to revisit the agonist replacement therapy for stimulant use disorders. I want to discuss some recent findings with single agents and combination therapies. And then at the end, I want to offer a few suggestions that I think might be able to improve outcomes or the translation of some of these findings that we see in the lab and in clinical trials. So agonist replacement for stimulant use disorders, I want to say that while I'm a proponent of this, really the champion of this approach was John Grabowski when he was at the University of Texas. John took some very fierce criticism for this approach. And it can, in fact, remember being at a meeting where Dr. Grabowski had given a talk, and there was a very heated exchange between one of the audience members and Dr. Grabowski about this whole approach. And but nevertheless, I think the data still suggests that overall this is possibly something to think about. And the premise is that the agonist will suppress withdrawal and produce tolerance to the positive or reinforcing effects of the stimulant. Theoretically, drug seeking and drug taking behavior should extinguish. And as Steve and I were talking this morning and reminiscing and just talking about things in general, agonist therapies have shown efficacy in the treatment of other substance use disorder. Methadone for opiate use disorders, nicotine replacement for nicotine use disorders. The evidence is very convincing for the agonist approach for those disorders. So, and if you look across the translational studies that are available, preclinical experiments, human lab studies, and clinical trials all suggest agonist therapy is a viable alternative um, for stimulant use disorders. So I want to, first, and I put this in red at the top, agonist treatment for stimulant disorders is not a novel idea. And this is back to a study and a figure that I love to present. It's a study by Roy Pickens in 1968. That's almost 60 years ago. And what they did is for they were looking at self-administration of methamphetamine, and then they would pre-treat them with methamphetamine. And from a medication development perspective, the best agonist for a drug is the drug. So, and what you can see as you go, and this is, a basic behavioral pharmacology study that was done. So, if you go down the lines, you can see under saline, they're taking methamphetamine at pretty regular intervals. A low dose of methamphetamine pre-treatment doesn't do much, but then at the higher dose, you can see that there's a pause. And Dr. Pickens and his colleagues concluded that the pause in responding might be due to satiation. So this was, the beginning of the data accumulating to support this approach. Um, Another study by Dr. Wilsons and Dr. Schuster, a past director of the National Institute on Drug Abuse, again, not novel, 1973. Um, this shows, cocaine self-administration in animals of 2.2 milligrams per kilogram per injection, and then a nice dose-dependent increase in the percent, and they're calculated as a percent change in self-administration, with the bars over to the left above the S representing the range of saline injections, of cocaine injections that they took when pre-treated with placebo or saline. And you can see that there's almost a complete suppression of drug taking with amphetamine for cocaine. This is a little bit more updated, or a little bit more current study. Steve Negus, who I would certainly call a valued colleague and a friend, 2003 with Nancy Mello. And I redrew this figure because I just couldn't get it to reproduce very well from the original publication. And they treated animals with saline, a low dose of amphetamine, and then a high dose of amphetamine. And you see that when they're pre-treated with saline, the open circles on the left panel, they take a lot of cocaine. And you see the typical inverted U-shaped curve that we often see with self-administration. And then with the low dose, you see this shift to the right, and but it is surmountable at the lower dose. But then when they treated them with the high dose of amphetamine, again, you see almost complete suppression at the higher doses of amphetamine for cocaine taking behavior. And they also, to determine the selectivity of the effect of amphetamine, they also looked at food pellets that they took per day. And you can see that when they're treated with saline, they eat normally, and the low dose didn't do much to pellet intake. But the higher dose did produce, a relatively dose-dependent decrease in food consumption, which isn't surprising, really. Amphetamines are appetite suppressants, and so, but it would be ideal if you could have a dose that was effective for suppressing or eliminating cocaine taking behavior, but yet didn't have an effect on other behaviors. Um, this is with methamphetamine from Matt Banks' lab, and Dr. Schwintek, I believe, was a postdoc at the time that they published this study. And you can see the individual animals. And I boxed in where what we saw is that the amphetamine dose, there was at least one dose in every animal that produced a discernible decrease in methamphetamine taking behavior. So again, pretty consistent with the whole notion that these will work. Um, this was our first trial with cocaine choices in humans here in Kentucky. And you can see following placebo, pre-treatment, there were six, up to six choices. They took most of them, five, a little bit more than five on average. And you can see that there was a decrease with amphetamine. And with the 20 milligram dose of amphetamine, or the 40 milligram dose of amphetamine, significantly reducing choices of the 20 milligram dose of cocaine. So again, consistent with the idea that amphetamines might work. Um, and then Josh Lyle, who was a postdoc and then stayed on as faculty at the University of Kentucky, got a nice grant uh, to it was a translational grant where they ran parallel studies in humans and in monkeys over at VCU in collaboration with Dr. Negus and Dr. Banks. And you can see again, there were nine choices, and there was a money alternative in this, so we didn't get maximal drug taking. Um, but you can see a dose dependent increase as they increase the dose of cocaine, and a nice suppression, excuse me, with the two doses of oral amphetamine. And this was a little better study than the one I authored as the first author, because they maintained their patients or their participants on amphetamine rather than we did it acutely. So it was a more clinically relevant study, in my opinion. Um, and then we looked at this is a study by Erica Pike, who was a graduate student with methamphetamine, and this using a progressive ratio, and they could earn up to 10 doses of the methamphetamine, and you can see they took most of it when they were on placebo, amphetamine, and there's a nice decrease, but no, it wasn't statistically significant. But you can see at the 10 milligram dose of D-amphetamine that the methamphetamine intake, or responding for methamphetamine, was decreased by about two choices. So that's like a 25% reduction in drug taking, but just did not attain statistical significance. But again, looking at it with a bit of a biased eye, admittedly, that this is consistent with the whole idea that agonist therapy might reduce methamphetamine intake. And then the clinical trial, and this is a trial done by Mooney, and this was in John Grabowski's research program. And this was, when I've written about this and in reviews and in chapters, I always call this a bold study, which some of the editors didn't like, and they wanted me to take the word bold out. But I liked it. I thought it was a bold study. They maintained cocaine users, or users of cocaine, on sustained release methamphetamine. And what you can see here is this across this 8-week trial, when they were on, the sustained methamphetamine, their cocaine intake gradually decreased. And by the end of the trial, they were down to about 90% abstinence. And I think this study goes under recognized, because in my mind, what this shows is that you can get near abstinence with a drug. Until this study was published, all the clinical trials were talking about fairly small magnitude decreases. And so, if nothing else, this is a nice proof of concept, is that in the clinic, we can get drastic reductions in drug taking behavior with the agonist approach. And this is the study with methamphetamine, and the data were not presented graphically, so I highlighted from the abstract that methylphenidate treated patients had significantly fewer amphetamine positive urines than the placebo-treated folks. And like I noted, unfortunately, data weren't presented graphically. But but there are concerns with the agonist replacement approach, and while potentially effective, I think many clinicians would be reluctant to use amphetamines to manage stimulant use disorders for at least two reasons. One is the potential abuse of the medication being used to treat the stimulant use disorder. And then, of course, they would probably be concerned about the cardiovascular effects in combination with the abuse stimulants, because in all likelihood, the patients are going to lapse or return to drug use. And you don't want a medication that if they do return to some drug use, have adverse event and they end up over in the emergency department. That would be obviously undesirable. But we think we've shown fairly nicely that these uh, shouldn't be the concern. I think that some people pay to them. Now, all the next couple studies that I'm going to present, these are all in active stimulant using participants. So these aren't normal college kids. These are the people that would likely receive the therapies if they were seeking treatment. They were non-treatment seeking. They just showed up. They were going to participate in the study and they were paid for their participation. So we also get subjective effects, and this is across a range of doses of D-amphetamine orally. And if you look at like drug, you can see that on a 100 millimeter visual analog scale, that's hanging out down around less than 20. It's in the lower quartile easily, and the same thing with good effects. And these measures are often used to measure abuse liability or abuse potential of these medications. This is another one where we looked at oral methamphetamine in people, and a little bit more robust effect. They're up around 30 at the high dose on like drug and good effects, but still, it's not this increase all the way up to 100. With these effects. So I think in these patients, you would have to kind of conclude that the abuse potential of these drugs is somewhat minimal. And I want to emphasize these were acute or immediate release formulations of methamphetamine and D-amphetamine. In all likelihood, clinically, I would propose that you'd use a sustained release um, formulation. And we showed years ago when I was in Mississippi that with methylphenidate, that sustained release formulations produce lower subjective effects than immediate release, because the rate of onset of a drug or CNS penetration is a critical factor in its abuse potential. The faster it gets to the brain, the higher the abuse potential usually. Um, what about the cardiovascular effects? So here's blood pressure. This is cocaine, dose range of cocaine in combination, when they were maintained on these doses. You can see that, yeah, the blood pressure goes up, but again, it's still less than 130 in these patients on average. So while it's statistically significant from the the control condition for cocaine, it didn't go off the scale. And our physicians that work with us in these studies were not alarmed by this at all. It was like, and I think the highest we ever saw in this study was we saw one patient get up to like 145 for a little bit. And it's just wasn't very alarming. The same thing is true of methamphetamine, that it's just, it's hanging out, about, you know, um, 130 when they're treated with the D-amphetamine, the squares. If anything, it's a little bit less than when we treated them with placebo amphetamine, and that could be cross tolerance to the cardiovascular effects. So again, not alarming. Um, and here's what happens in the clinic. If you look at the circles are when they're on the group that was maintained on placebo, and the filled squares and triangles are the immediate release amphetamine and the sustained release amphetamine. And you can see that there's lots of variability, but in most instances, the amphetamine is below the placebo doses, or if it is above it in some instances at the end of the trial with the immediate release. But again, with the immediate release is not the formulation that we would recommend. And at the end of the trial, you can see with the sustained release, it was below or at placebo levels. So, and again, even at when you see the immediate release at the end of the trial, it's still less than 135. So again, not alarming to folks. So I think in summary, the preclinical, human lab, and clinical trials suggest agonist therapy may be viable. The potential for abuse in cardiovascular interactions with the abuse stimulant appear to be minimal, at least in our hands. So, which brings me then now to some recent findings with single agents and drug combinations. And this is a study. This was such a fun study to do. I collaborated with a group out in San Francisco who was headed up by Phil Coffin, where I helped him write the grant or the human lab part of the grant, and I had some meetings with him throughout the course of the grant. But it wasn't very demanding, to be honest with you. And all of a sudden, they sent me all this data to write up, which is like great. It's like I got all the benefits without all of the kind of day-to-day issues of conducting these studies. So mirtazapine is an antidepressant. It facilitates release of the three major uh, neurotransmitters thought to be involved in stimulant abuse: dopamine, norepinephrine, and serotonin. Um, Two trials previously showed that 30 milligrams a day reduced methamphetamine use. So as this was part of a U grant where we were running this kind of safety study with mirtazapine in combination with methamphetamine. But I thought, well, listen, if you're in there, giving them the drugs, maintaining them on mirtazapine and giving them methamphetamine, let's get some behavioral data and see what we find, which they were amenable to. So this is the data, and instead of self-administration, we used a drug demand task where um, they got drug in the morning under placebo or mirtazapine on separate dosing regimens. Um, but it was totally within subject design. And then in the afternoon, they were asked, how many doses of this would you purchase at this price? And then the prices escalated and you get a break point. But what you can see is under placebo, they break at about $66, but under mirtazapine, they broke at about 53, which was significant, modest effect size. And then you can see over to the right panel the four conditions that mirtazapine was safe when combined with methamphetamine, and this was intravenous methamphetamine. You can see, though, that the systolic pressure, it's practically on top of each other when the methamphetamine was given with zero mirtazapine or with the 30 milligrams. So again, no cardiovascular concerns. And another study that we did looking at topiramate, phentermine combinations to reduce self-administration. I'm going to tell you, if I could pick one study out of my career to be, really the most proud of it, I think this one was one of the best studies that we did at the University of Vermont, or University of Kentucky. So why topiramate? It's a glutamate antagonist and a GABA agonist. Glutamate and GABA are abundant neurotransmitters in the brain. Cocaine exposure lowers glutamate levels in the corticostriatal areas. Um, Phentermine is a dopamine agonist. It's a stimulant. And glutamate activity in the nucleus accumbens. It's a complex that it affects the actions of GABA neurons, which in turn regulate dopamine activity. Um, and topiramate and stimulants have shown the largest improvements in abstinence from cocaine if you go back to the Chan meta-analyses. And uh, a upside to this combination is it's available as a weight loss a weight loss medication, Qsymia, which I think repurposing medications for substance use disorder um, has some benefits. So it was a mixed model. The phentermine doses across the top, they were maintained for 4 days to get the steady state. And you can see that those are the 0, 15, and 30. And then going down the columns is the topiramate doses, but those were between subjects. So we had 11 in the placebo topiramate, 9 in the 50 milligrams a day, and 11 in the high dose of topiramate. And outcome measures included responding for cocaine on a progressive ratio task, as well as cardiovascular indices. Um, so this is what happens with just the phentermine with zero topiramate. And if the dose effect curve symbols are filled, it means they differ significantly from the dose effect to the left, the placebo condition. So you can see here that there's a modest reduction with phentermine with both doses. Um, not overwhelming. Then when you add the 50 milligrams of topiramate, you see there's also a reduction with topiramate alone, but it didn't differ from the placebo condition. But the middle with the middle dose of phentermine, it did differ, and then the higher dose of phentermine didn't differ significantly from the far most left dose effect curve. And I really think that happened because at the 80 milligram dose of intranasal cocaine, self-administration dipped down. So, you can, oh, wow, we got the inverted U-shaped curve, but that usually you have to go to much higher doses to truly get an inverted U-shaped curve. So I think that was just some variability. Uh, but then these data, you can see when we got the group with the 100 milligrams of topiramate, you see a very striking decrease in cocaine taking behavior. And the triangles to the right obviously differ significantly from the far left circles. But at the middle dose, at the 40 milligram dose of intranasal cocaine, that's a 74% reduction in cocaine taking behavior compared to over to the left, the 40 milligrams. That is, to my knowledge, the largest laboratory reduction in cocaine taking behavior observed. But there could be studies that I'm not aware of. Um, the cardiovascular data, again, this is heart rate. Yeah, as expected, heart rate goes up with phentermine, but they're not even tachycardic. Uh, they're, well below 100 beats per minute. And if anything, there's a little bit of a reduction with topiramate offsetting phentermine's effects, or no effect up at the higher dose. So again, this, conclude that the combinations are safe. Um, so consistent with this, at just about the same time we were conducting the lab studies, Fran Levin was running a NIDA-funded clinical trial looking at the mixed amphetamine salts and topiramate combinations for cocaine dependence. And they had showed that it was effective previously in a smaller trial, but this was to replicate with a larger sample of participants. And again, nice data showing that with the odds ratio of at the end of the trial, it was in favor of the the combination trial or the combination group. Um, and if you look at any 3 weeks during the trial, it still clearly favors the combination treated participants. Though you can see it's not a striking difference. I mean, it's 14% and then about 15% at any 3 weeks. So we would like more, but again, this is proof of concept. But Fran Levin and I had some enjoyable conversations about trying to advance this, but there just was very little interest in this combination at NIDA. Wrote, I wrote this multi-dose trial, and then they said, no, you should just compare placebo and the combination. Well, I revised the grant, send it in, and then it gets criticized for not testing multiple doses. And it just became clear that they weren't interested in it, but which is unfortunate. Um, but in the vein of medication combinations for stimulant use disorder, there's been a lot of interest in bupropion and naltrexone for methamphetamine use disorder, and this is out of a lab down in Texas, University of Texas Southwestern, I believe. Um, so. Why bupropion and naltrexone? When I was putting together this talk and I redid this slide from another talk, I thought, that's a really good question. Why? You know, if you look at bupropion and naltrexone alone in previous trial, they showed very weak evidence to increase abstinence. This study out of the UCLA group, they found no significant difference between uh, abstinence with bupropion and placebo, about 15%. It approached statistical significant, but did not reach it. And Coffin and colleagues did a study previously where there was with extended release naltrexone. About 20% of the naltrexone treated group were absent at the end of the trial compared to placebo, 14% in the placebo arm. And in their discussion, Philip made an accurate but bold statement. He said, "We found no evidence of efficacy for extended release naltrexone." But the upside is the combination of bupropion and naltrexone is available for weight loss, and that's Contrave. So again, the path to approval is probably a little smoother for a medication or a medication combination that's already been approved for another disorder. So here are the data from the Trivedi study, and they used a really nice design. I cannot criticize the methods they used. They had a stage one where they were randomly assigned to bupropion or naltrexone or placebo. And then at the end of stage one, they were re-randomized to stay in for stage two for those that were non-responders. And the response was 3 out of 4 methamphetamine-free urines at the end of the stage one, which was 5 and 6, and stage two, weeks 11 and 12. And you can see that it was the weighted averages. It was a little lower or it was quite a bit lower. The weighted averages between the naltrexone bupropion treated group, as well as at the end of stage one and stage two. But again, using the weighted average, there was only an 11.1% difference. I mean, that's really pretty small magnitude. Um, but there still continues to be a good bit of interest in this combination with NIDA. And I think they might have a trial going under the CTN, but I'm not sure if that ever came to fruition. Um, and then, and honestly, if you look back at this study that we did years ago, where we looked at naltrexone and bupropion alone and combined, they didn't alter the reinforcing effects of intranasal methamphetamine. You can see here that the dose curves are the four combinations with placebo way to the left and the bupropion naltrexone way to the right. If you look at the diamond's way to the right and compare it to its circle over to the left, um, there's no difference. There's no difference at the high dose, um, and there was some reduction with the drugs alone. If you look at the lower dose of methamphetamine, but it wasn't statistically significant. Uh, and in one of my if I was going to criticize the Trivedi study, and it's a clinical trial, it was a big trial. Um, is they just tested the combination. You don't know what's contributing. Was it naltrexone doing the work, or was it bupropion doing the work? We don't know when you only test the combination, but testing multiple doses of combinations in a clinical trial would be a massive undertaking. Um, so summary for single agents and combinations. Pyramide and phentermine, they show potential. Uh, Mirtazapine as a single agent shows some efficacy for methamphetamine use disorder, while a combination did not show efficacy beyond the results observed previously with the constituent drugs alone. The 11 to 16% reduction with the combination is what you saw basically with bupropion or naltrexone alone. So it's really, at this point, difficult to conclude that the combination uh, is any more effective than the drugs alone. But I appreciate a lot of what's driving this is that repurposed medications probably get approved more quickly than a novel molecule. If you look back historically, bupropion was first synthesized in 1966 and then approved for opiate use disorder in 2002. That's 36 years. That's a long time. The problem is now. We'd kind of like something quickly. Um, so, what are some of my methodological suggestions to hopefully improve trial success or translation? Um, First of all, we've got to start looking at testing these patients or these medications in patients with comorbid opiate use disorder. If you look at these data from the CDC, a lot of if you look at the stimulants alone, that's total deaths, but the yellow bars show in combination with synthetic opioids other than methadone. And you can see it compared to stimulants without any opioid on board. It's striking. The problem is really more pronounced in combination with opioids. But bringing in patients with both disorders, it complicates it. In my experience with the comorbid patients is they present with a whole host of more severe psychiatric conditions as well as health conditions. But if you look back, and to Dr. Chan was really busy during those 19 and 20, so it must have been during COVID, basically. If you look at the medications tested in with comorbid opiate use disorder, only 22 medications are tested. Moderate evidence for antidepressants, but in the wrong direction. They worsen retention. Low strength evidence for stimulants, Mazendal and amphetamine to reduce cocaine use, though not statistically significant. And there was only one trial for methamphetamine use disorder in patients with comorbid opiate use disorder. But they concluded, most medications were ineffective. Uh, but we definitely need more research. But these are complex studies. Another issue, clinical trials in substance use disorders, in particularly, are adversely affected by high rates of patient dropout and patient or poor clinic attendance, and high rates of non adherence or not showing up at the clinic make data analysis difficult, and it often leaves the endpoint analyses with insufficient power, which is a concern. And I don't need to preach to this group about the virtues of contingency management. But, you know, using contingency management, not to target drug use, but to target clinic attendance is very effective. We did this clinical trial for this behavioral intervention, inhibitory control training. And while that didn't work, what we did see was attendance was averaged 93% across the 8-week trial. And but in subsequent medication trials, I always included, we're going to use contingency management to improve or maximize clinic attendance in the provision of urine samples. They didn't like that. The reviewers would come back with, well, that could differentially affect the groups. And I would respond, well, the groups are both getting it. So it shouldn't uh, theoretically react or respond differently, but they just would not. I didn't do my job to convince them that that was important. So, and then of course, there is interest in abstinence versus reduced use as an outcome measure. Um, this is one meta-analysis that looked at. There's 3 groups. There are people that showed no drug reduction. The blue bars, the orange bars are those that showed reduced use, and then the gray bars are abstinence. And what you can see is across these measures, drug use and psychosocial functioning, that they all the abstinence and reduced use differed from the no reduced use on all these measures, but there were many instances where abstinence produced more of an improvement. And if you see it, look at these other measures that they included, same thing, reduced use and abstinence differed from the no reduced use. Abstinence and reduced use differed on all the measures except for craving for other drugs. And data that they didn't produce graphically, but I thought were critical, was abstinence and reduced use also differed significantly on stimulants in the urine, as well as HIV risk behavior at the end of the trial. So at this point, I think my conclusions are the reduced use results in improvements relative to no reduced use. Reduced use does not achieve the same level of improvement as abstinence on most measures. But this research is really in its infancy, and more research is needed, in my opinion. And finally, my last slide about human lab studies. Human lab studies are intended to be a bridge between clinical work and clinical trial, or preclinical work and clinical trials. Yeah, the bridge needs some work. I think we've done a really good job. And, like self-administration is the gold standard. I've used it exhaustively in my career. But I think we need to look to other outcome measures to test these medications before launching them into a full-blown clinical trial. Measures that you can test in patients seeking treatment. In all our studies with these medications, they were non-treatment seeking, because it's the vast majority of people say it's unethical to give drugs of abuse to people seeking treatment. We used to call treatment the T word. If they showed up seeking treatment, we gave them a referral, but they were immediately deemed ineligible for any of our studies. Um, I think the drug purchase task, which it can be used without any drug administration, which would make itself very amenable to use with patients seeking treatment. And behavioral interventions and pharmacotherapies for other substance use disorders have been shown to decrease intensity. So, I think it's something we should look into. So, with that said, I want to thank you for listening to me. It's been wonderful visiting with my friends and colleagues from the University of Vermont, and still very much. Just cannot tell you what a great experience it was at UVM. I still have a UVM sweatshirt that I wear.
Great, great. Well, thanks for an excellent talk, Craig. So we have 5 minutes for questions. Please send them through the Q&A button. And we have here one from John Roll, Craig. John says this was a nice way to start my day on the West Coast. Do you think hypothetically that we should be looking at different drugs or behavioral interventions for the initiation versus the maintenance of abstinence?
Yeah, John, that's a great question. And yes, I do. Uh, I always thought it would be ideal to get them abstinence with high voucher CM, and then introduce them to a medication to see if you can sustain that. And yeah, I do. I don't think there's going to be a magical bullet that gets people to abstain. And it was refreshing when I was at the University of Texas a year or so ago consulting to their T32, where one of the other external board members, who was a very renowned preclinical behavioral pharmacologist, said, I really don't think we're going to have a medication um, for cocaine substance use or for cocaine use that works on its own. And I said, well, no, you're going to have a behavioral intervention accompanying it. A medication, in my opinion, is an adjunct.
So while we wait for other questions, Craig, I'll share one thought. When you were saying about using CM to facilitate attendance in these drug trials, and so you get it at least have the people take the medications that you're trying to test. It's just a head slapper for me. I remember 20 years ago having that same thought because people who were doing the trials, they would often remark that, it was an unsuccessful trial, but many of the people didn't take the medications. Thought,
Right.
oh my goodness, standing right next to us. And at that point, there were separate, um, groups in NIDA who were doing the medications development and behavior therapy development, like look right across the hall,
Yeah.
at least get them to take the medications, but apparently that's
Well,
not been surmounted.
well, no, and it's very short-sighted, in my opinion, because when I was the editor or associate editor of drug and alcohol dependence, I can't tell you how many clinical trials for medications I handled that would say, well, if we, do explore the data and look at just those patients that were deemed to have taken the medication at least 80% of the time. Well, there were medications that worked. Well, I
Hmm.
thought, well, come on, let's figure out some way to get them to take the medication. And we used clinic attendance because we weren't giving a medication in that trial. We just wanted them to show up at the clinic to provide their urine sample and do the training on the behavioral
Right.
intervention. And it worked beautifully, 93%. And that average was brought down because one of the participants was incarcerated during the first week of the trial and never showed up again. So we had to keep counting him, of course, but it would have been a little higher if it hadn't been for that participant. But still, it was very high, and I just couldn't convince them because we were going to use an electronic medication device where we would, if they took the or at least if they opened the device, they got vouchers, and they didn't want it. Well, that's not the way it's going to work in a clinic. Well, I know that, but this is proof of concept. Let's see if we can get the medicine to work under ideal conditions, and then we can worry about that stuff down the road.
Yeah, but today it could be a combined therapy. SAMHSA has
Yeah.
said that you can now use federal funds. One more question. I mean, what we're shooting for here, if we use buprenorphine and methadone substitution therapies as models, is a stimulant-like medication that can substitute in terms of having reinforcing effects of its own, but is a little bit of an inferior substitute relative to the abused substances. Which one, given all your experience, is the one you would point to you think has the best potential in that regard?
Sustained release methamphetamine. It's what
Okay.
the clinical, but that is just not going to ever fly, you know. But that's where, in my opinion, where the strongest data is, and
What about sustained release methylphenidate?
that hasn't that for some reason methylphenidate just hasn't produced the effects. But in one conversation I had, you know. I think it was a dosing issue. They would test they'd test 30 milligrams of methamphetamine, for example. Well, the potency relationship between methylphenidate and amphetamine is about 2 to 1. So you should be testing about 60 milligrams a day of methylphenidate. That is getting up pretty high because, people are then locked into the doses that are used therapeutically for ADHD and largely in children or adolescents, so I think that was just a dosing issue.
Right, right. Well, it looks like we're out of time, Craig. So thank you very much for taking the
Yeah.
time to be with us today. It was an excellent
Yeah.
lecture, and thanks to everyone in the audience for being
Yeah. Thank you.
really.
Thank you for listening to me. I appreciate it.
All right. Enjoy, everybody.
Thank you,
Yeah.
Steve.
Bye-bye.
Bye now.